Coming on to our next section, session 11, some problems which we all face. May I invite to chair the session Dr. Amulya Singh sir, Dr. Bhuvan Singh sir, and Dr. Prakash Dhillon sir. The first speaker is Sanjeev Patnaik sir, the management of defects in TKR and in revision scenarios.
Hold on a second. Take a second, okay? I think Mr. Patnaik. This one, sir? Raise your pointer. You have to go like this, right click. Thank you.
Yes, Dr. Sanjeev.
Yeah.
Great to see you. And you are very particular of your attendance in Anup Master's course, and we are obliged that whenever you come here, we learn a lot. So over to you.
Thank you, Chairperson, sir. At the outset, let me thank Dr. Ashish Singh and the entire organizing team for inviting me in this prestigious conference. The topic which has been allocated to me is bone defects in total knee arthroplasty. What are the management protocols? Now, this is the outline of my talk, where I'll be delving on etiology of the bone defects, various classification systems, how do we plan properly, management strategy, and the take-home message. Now, bone defects in total knee are very common, not only in the revision scenario, but also in the primary TKR, each which presents unique challenges. And the management can sometimes be very controversial in order to ensure a good functional implant with long-term survival. Knowing the etiology of the defect, localizing and classifying it will help in the overall management. Now, the etiology in primary total knee arthroplasty is especially either it is osteonecrosis, bone cyst, it may be a sequelae of fractured tibial plateau or femoral condyle, any inflammatory arthropathy, or previous tibial osteotomies. In the revision scenario, it could be due to aseptic loosening, osteolysis, stress shielding, septic loosening, iatrogenic, resulting from implant removal. The various types of bone defects, if in the simple terms, it's based on the size, it may be less than 5 millimeters, 5 to 10 millimeter, or more than 10 millimeter. Based on the location, central or peripheral, based on the margins, it may be a contained or an uncontained defect. Now, we all know that varus knees have a defect on the posteromedial tibial plateau, and the valgus knees, the bone loss is usually centrally on the tibial plateau lateral, and deficiency of the lateral femoral condyle is seen. Now, various classification systems, the most common based on pre-operative assessment or intraoperative assessment, these are the classification systems we need to see. Now, the most common is the Anderson classification system, commonly used. It considers the role of remaining bone on the implant, divided into 3 types on the femoral and tibial side, type 1, type 2, A, B, and type 3. Now, the defects which is seen in the revision TKR, especially we need to know whether it is affecting the epiphysis, metaphysis, or the diaphysis. Now, what are the goals of reconstruction in any bone defect in TKR? We need to preserve the remaining host bone. We need to restore the anatomic joint line, restore the longitudinal, angular, and rotational stability, and the ligamentous stability. And the flexion, extension, symmetry, and balance needs to be maintained, and we need a secure implant fixation. The preoperative assessment, as with any total knee arthroplasty, with full x-rays, full scanograms, serial x-rays sometimes are required in revisions cases to see the progression of osteolysis, subsidence of implant and radiolucent line and implant migration. Sometimes 3D CT scan is also helpful. MRI can quantify the osteolytic defect, and bone scans may also see if the infection is incipient. Now, implant selection depends on collateral ligament and extensor mechanism integrity, the degree of bone loss, integrity of residual bone. The choice of implant usually is a PS knee, or maybe an unlinked constrained knee, or a rotating hinge, or lastly, modular prosthesis. Now, management options are if you see increased tibial resection where we alter the joint line, translation of the component away from the defect, filling the defect with bone cement, cement filling plus screw augmentation, bone grafting in any form, metallic wedges and augments, customized implants and mega prosthesis. So we go one by one. Now increasing the bony resection, a thicker tibial resection to the base of the defect is reserved only for the shallow defects. And various studies, they show that decrease in the strength of fixation of component is by 33% if you have a more than 10 millimeter tibial cut. And the attachments of the IT band, pes anserinus, patella ligament all may be compromised if you go below 10 millimeters. And it may lead to a smaller tibial component, decreased surface area and increased unit loading. And the thumbs rule here is always safe to keep the tibial cut just above the tip of the fibula head. Now translating the component away from the defect, it is used for peripheral defects less than 50% of the condyle. That requires a smaller tibial component lateralized for optimum coverage and better patellar tracking. It may alter again the force transmission across the implant and subsequent loosening. Now cement in bone for the smaller defects less than 5 millimeters, it is easy to use. For small circumscribed contained defect, we can use bone cement. And we can also use cement plus screw augmentation. That is, again, it provides a level surface upon which to seat the implant for late failures. Now the screw heads, it should be slightly below the level of the implant, and it adds to the mechanical strength of the cement and prevents fragmentation and lamination. Now these are some examples where it's a cement screw construct is used, downsizing of the implant and the lateralizing of the tibial component is used. Now these are the examples in such a grotesque deformity. You can get away. This is again a posteromedial defect, well corrected by using cement and screw construct in the tibia. Now bone grafting can be autologous or allograft. It is indicated for peripheral defects more than 50% of the condyle and depth more than 5 millimeter. So advantage here, it provides more physiological load transfer. It requires screws or pins for fixation, but intrusion of cement into the host graft interface must be avoided. There are chances of malunion, non-union and late collapse. And allografts can be used from the femoral head and morselized bone graft, especially in the revision scenario. Now this is an example of tibial flip autograft fixed with screws. The advantage is you can avoid use of customized implant and avoids possibility of cement fragmentation. It preserves the subchondral bone for future revision. But disadvantages, the limited supply of bone graft, fashioning into the given defect may be difficult, and graft incorporation may be unpredictable. Now these are the examples, autologous bone graft fixed with screw construct for tibial defect with a stem tibia. Now, exposure of the bleeding bone has to be there, precise fitting of the graft, and rigid fixation with screws is required, and component coverage by the graft. Metallic wedges, they are quick. You can apply it very quick, no donor site morbidity, gives immediate stability and load transfer. And rectangular wedges may be superior to the angular wedges owing to the decrease in the shear stress. Now coming to the example of metallic wedges, now disadvantage, it can require more bone resection sometimes, potential for debris generation and osteolysis. And intramedullary stem extenders are a must. It imparts angular and rotational stability and offload stress to the diaphysis almost by 30%. And the controversy exists in cementing of these stems. Now, varus, this is one example, varus with type 2B posteromedial tibial defect with ligament laxity, as you can see here, managed with a wedge. Now, these wedges are especially suitable for elderly osteoporotic bone, affords favorable load transfer from metal to bone, allowing immediate weight bearing. This is the example post-op. Now, another post-traumatic case in which femoral augments have been used. And as you can see here, this rotating hinge knee has been used in this case, and these are the 3-year follow-up of the patient. Now, larger uncontained bone defects. Now, customized implants, they provide excellent force transmission between the implant and bone, precise fit to the defect, but it may be expensive. Now, the metaphyseal fixation by porous sleeves and cones or the structural allograft may be required. Now, indications are poor bone stock, impaction grafting fails to achieve implant stability, and additional longitudinal and angular support is required. So these are large uncontained femoral bone loss with porous metal augment, provides a stable foundation for cementation of the femoral component, and careful seating of the augment is also important for appropriate rotation. Now advantages, it fills large defects, there is no risk of disease transmission and osteointegration without the risk of graft resorption, and affords primary rotational stability. Now these are morselized bone graft, can be you can use it along with porous tantalum metaphyseal cones. Now trabecular metal cones, they are relatively new solutions, superior osteoconductive property, but its high cost is the impediment. Now long-term follow-up is required in such cases. Now metaphyseal sleeves for severe metaphyseal deficiency in zone 2, it provides axial as well as rotational stability, and therefore it's made up of titanium with sintered bead with 50 to 80% porosity. Now it provides axial and rotational stability. Now combined wedge and metaphyseal cones can be used. This is versatile. Now allografts not needed to fill the void, but the potential to reduce intraoperable, no broaching is required. They are expensive. That is the only thing. Now futuristic solutions are there. 3D printed trabecular metal cones and wedges are now available. Distal femur megaprosthesis, these are reserved for complete destruction of the distal femoral condyle, where complex bone defect you can always bail out through the megaprosthesis, where there is loss of collateral and extensor mechanism integrity. So these are the bailout options you have. So the take-home message, a careful appraisal of the extent and location of the defect will help in decision-making. Preoperative planning and templating is essential. Each case should be individualized. Smaller defects you can get away with cement or morselized impaction bone grafting. Medium defects 5 to 10 millimeter you can get away with autologous bone graft plus minus stem extenders. But if it's a large uncontained defect, you might require autologous bone graft plus minus stem, and metal augments or wedges are useful. And large uncontained femoral defect involving one or both the condyles will require augmentation with either metaphyseal sleeve, cone, augments or structural allograft. Now finally, this is a simple algorithm to take away for the bone defect, whether it is contained or uncontained, and I would thank you for the patient hearing. Thank you very much.
Thank you, Dr. Sanjeev. Any question from the house? Dr. Sanjeev, which condyle defect you find it difficult to manage? It's the medial side or the lateral side?
I think the lateral side is most important, because these are the valgus knees especially, which have very small lateral femoral condyle. The femoral side is very difficult because you have to use wedge, because in this case bone grafts do not accept very well because of the shear which is there, the shear forces. So you have to use metallic wedges, especially if you have smaller lateral femoral condyle. So I would be, I would say that the difficult part is the lateral femoral condyle, which is difficult to address.
Right. Thank you very much.
Yeah.
Any question from the house? Dr. Mahesh, you want to ask some? There is one question from the Dr. Mahesh, the Secretary of Bihar Orthopedic Association.
Hello, Dr. Sanjeev, it's Dr.
Dr. Arvind.
You said bone graft is not very well to shear, not very well to take care of the shear forces. But anyway, you are using the stem there.
Absolutely.
Along with the plate.
Yeah.
So in that case, bone graft, if it incorporates, it's throughout the life of the patient. That is not going to be given by your metallic wedge.
Yeah. It is definitely useful to use a longer stem in the femoral side. You are talking about the femoral side.
Both, either femoral or tibia.
So most important, you have to fashion the bone graft in a way that it fills the defect. Yeah. Sometimes you may have a problem with the amount of bone coming out from the cuts. You may not get that appropriate size of bone graft. That is one issue. Yeah. And number two is that if it is sclerotic, if the bones are sclerotic, sometimes it can be an issue in the graft absorption of the graft.
Yeah, definitely.
Yeah.
A sclerotic bone should not be used.
So in those scenarios, to give immediate stability, metallic wedges will give you that bailout. Because immediately you can go for weight bearing, because you are not concerned about bone resorption in that scenario. And more important, especially when you are dealing with the posterior femoral condyle, the stress forces are immense. And in that scenario, if you have a wedge which is totally fixed with the implant, that gives better stability as compared to a bone graft, which may or may not absorb properly. That means it may not unite properly. And you need to fix it properly also. There are concerns that cement can go inside the bone graft also, if you have not adequately fixed it and well compressed it. So there is chances some amount of cement might enter it, and that may be a hindrance for that bone incorporation.
Thank you.
Thank you.
Thank you, sir. Very impressive lecture. My question is something different. There is so many modality of treatment for revision or failure cases. But I would like to ask, if a patient is elderly, they had a primary knee replacement, they failed with infection.
Okay.
So a patient is elderly and failed, and second thought of the infection. So what is the way out of this kind of patients? Either do a revision surgery to wait for the control the infection and then do a total knee replacement revision, or some other kind of situation, then we weigh out the things, solve the problem.
If it is an infected TKR, then we have to definitely clear the infection. That is the most important consideration. That is, the bone loss is become secondary in that scenario. So first we need to address the infection. We may go for two-stage revision, and in doing the primary, the first stage revision, we need to clear out all the infection, all the soft tissues, adherent soft tissues, do a good debridement, thorough debridement. We do not care about some amount of bone coming out, because in any case you are removing the implant, the cement will take out some amount of bone, but we are not concerned about that. We need total, that infection has to be totally 100%, we have to be sure that there is no infection. Then only we will come and address again in the second stage. We do a thorough CT scan and see the amount of bone loss, and accordingly we plan what we require. We have metaphyseal sleeves, we have wedges, we have even bone graft can be used from the corticocancellous bone graft from the iliac crest we can use. Then accordingly we have to plan. But first priority should be given for infection to be taken care of.
Okay, thank you, sir.
Thank you.
Thank you, Dr. Sanjeev. May I request Dr. Bijay Kumar
Thank you.
to present his case.